Hi, it's Dr. Centeno. Thanks so much for joining us today. I was just getting back. I got back to the States on Friday evening and decided to do a Facebook Live today. And basically, since I didn't have a lot of prep time, I'm going to redo one that I did previously. It's basically understanding how Chiari causes symptoms, because this is an important one. I see so many patients who don't really understand why they have symptoms with Chiari. And most believe that it's a structural issue that needs to be fixed structurally with surgery. And there are some Chiari patients out there like that for sure. But most don't understand that there are probably other things causing symptoms, and consequently, it's hard for them to make good choices on what type of procedures to get, if any, to try to help their problems or issues. So I wanted to redo this one a little bit, open up Q&A. Again, I'll do probably 10, 15 minutes of direct discussion with a little bit of a lecture. And then we'll get into Q&A about this topic or really anything else. So if you're just joining us here, I just got back in the States on Friday night, still a little bit jet lagged, but I wanted to get one of these out since I hadn't done one in about 6 weeks or so. And kind of advertise this last minute. So hopefully we'll have a reasonable number of people on here. Format is as usual, where I'll do about 10, 15 minutes on a topic. And today it's going to be understanding how Chiari causes symptoms. And then we'll go from there into Q&A, whether it's about this topic or really anything else. So we'll get started here while we wait for a few people to sign on. Again, don't know quite how many people we'll have today just because I didn't really advertise this too heavily. I was kind of getting over jet lag and trying hard to get anything done yesterday. Today, I'm a bit better. So we're going to talk about Chiari and symptoms. And this is a big one because most Chiari patients believe that they have a structural problem. And there are some Chiari patients that do have primarily a structural problem. But most Chiari patients have a structural issue plus another problem that causes symptoms. So there's lots of people walking around out there, for example, with Chiari 0 and Chiari 1, and that Chiari 0 and Chiari 1 by itself is probably not causing their symptoms. It requires another thing in the mix for them to get symptoms. And so since this one is so widely misunderstood, I wanted to really get into this again today. So we're going to start with this, and then we'll get into Q&A. You can ask questions about this or anything else. If you want to ask questions, then the best way to do that is just, no matter where you are, whether on YouTube or Facebook, just start putting questions in the chat here or in the comments wherever you are. So that's the best way to ask a question. So let's get into this here, understanding how Chiari causes symptoms. So as you may know, most people have a situation where their brain fits in the skull case. And if we draw a line across the bottom of the skull base, the back of the brain sits above that line. And if the back of the brain is a little bit lower and touches that line across this hole in the bottom of the skull that we call in Latin the foramen magnum, or Latin really big hole, then that's called Chiari 0, also called CTE. And that's pretty common. There's a lot of people walking around out there that have Chiari 0s, but don't really have any symptoms. And then if that back of the brain goes below that line, less than 5 millimeters, we call that a Chiari 1. Again, there's people walking around out there with Chiari 1s who don't have symptoms. So that's the big mystery in Chiari, right? I think most patients believe I was born with this structural thing and someone's got to go fix the structural thing. The problem with that as an idea is that there's lots of people walking around out there that were also born with that thing, i.e. Chiari, that don't have any symptoms at all. So what explains symptoms in Chiari? And that is still something that's being discovered, being unearthed as we speak. And it's important for patients to understand that, because at the end of the day, we think the structure has something to do with it, but there are other parts and pieces that are important too. So do we really know that Chiari malformation by itself causes symptoms, especially in Chiari 0 and Chiari 1? And the answer is no. There's little high-level evidence that shows a direct correlation between Chiari 0 and Chiari 1 and symptoms. There are certainly a bunch of theories, and some theories have more evidence than others. But this is a critical thing for patients to understand. It is critical, if you've got Chiari and symptoms, that you understand that the structure by itself, based on what we know right now, is probably not causing your symptoms. It's the structure plus something else. And that really dictates the kind of treatment you would want to pursue. Now, you might be saying to yourself, now, wait a minute, I heard it's all about the stopper effect. So what is the stopper effect? The stopper effect is this idea that as the back of the brain comes lower, it acts like a stopper in the top of a bottle. And that messes with the normal cerebral spinal fluid flow, because CSF is what the brain kind of hangs in. It's floating in cerebral spinal fluid. And we have to have normal flow of that cerebral spinal fluid in order to try to get rid of waste from the brain, in order for us to have normal brain function. And we're learning more and more about that flow. For instance, Scott Rosa in upstate New York is one of the pioneers in using cine MRI in understanding that normal brain CSF flow. So again, the stopper effect here is that in a normal cine MRI, you've got flow in front of the brain and spinal cord and behind the brain and spinal cord. And that in a Chiari patient, you see blocked CSF flow in the back. Now, that by itself would seem to be an amazing revelation, right? We can now image the flow of the cerebral spinal fluid, which we're pretty sure is an important thing. And if we find it abnormally disrupted by the Chiari, then the logical conclusion would be we want to open that area up. The problem is that it's a little bit more complex than that. And so we're going to go into that a little bit. So do we really know that CSF flow causes symptoms by itself? And the answer from this study was not really. The CSF flow near the foramen magnum, again, that big hole in the base of the skull, did not differentiate symptomatic from asymptomatic patients with Chiari 1. So that kind of blows the whole theory, right? It blows the theory that it's the Chiari itself causing a stopper effect and blocking the CSF flow that is the main problem. And that then starts to call into question why we would need to decompress patients if, in fact, this is not really causing symptoms. So as I said, this is a little bit more nuanced than it looks. And it's important to get into that nuance, and it's important for a patient to understand that nuance, because if you don't understand that, you're not going to be really clear as to what is causing symptoms, and not going to be really clear as to the best way to solve your problem. So let's get into this here a little bit. So this is a different study here. This is a study that, I'm going to make that a little bit smaller there. So this is a study that basically says maybe there is a difference. meaning this study looked at CSF flow, like we were talking about in the other study, but it added in the concept again of looking at Chiari-1 and CTE. And in this study, they thought there could be a relationship between the two. They weren't 100% sure, but they thought there could be a relationship between the two. So we have one study that says there's not a relationship between CSF flow of the foramen magnum that we would measure with a cine MRI. This study says that maybe there's a relationship between that and symptoms. So another problem that we've had that I've talked about already is that we have people walking around with Chiari who don't have symptoms. So if that exists, and if that's fairly common, it kind of calls into question whether or not the Chiari by itself is causing symptoms. And these are kids here we're talking about in this study. And that's one of the problems with the Chiari literature in general, is that most of it has been looked at in kids, not adults. So what does the research tell us? Well, the research tells us something interesting. It basically says that if you've got Chiari plus something else, that's what's causing symptoms. So that's the nuance I was talking about before, right? It's not just the Chiari thing. It's the Chiari thing plus something else that is probably causing symptoms. So far, what the research shows is two factors. One factor is craniocervical instability. The other is atrophy of an important muscle that really opens the back door here for CSF flow despite the Chiari. So let's get into these. So Chiari-1 plus CCI. So this is an interesting paper that was published a number of years ago. And again, it's trying to answer the mystery, right? The mystery of why do we have people walking around with Chiari and no symptoms? And what it was able to do, interestingly enough, is to look at this concept of C0C1 instability. And they looked at it in an interesting way. They looked at the depth of the C0C1 facet joint. So what they tried to do is to say, if someone has a more shallow facet joint at 0,1 between the skull and the atlas, then that's probably going to be more inherently unstable. And if someone is more inherently unstable, then it would make all sorts of sense that they have craniocervical instability or are more likely to get craniocervical instability. Then they mapped it all out and they tried to see if patients with flat joints at 0,1 were more likely to have symptoms if they had Chiari or less likely. And they found a direct relationship between the two, that if you had a more normal, deep-setted ball and socket type joint at 0,1, you were much less likely to have symptoms. If you had a more shallow joint that allowed sliding at that level, you were much more likely to have symptoms. So in summary, if you had this shallow joint, and the idea being much more likely to have craniocervical instability and Chiari, then you got symptoms. If you had Chiari plus a better joint, a better constructed joint there, you were less likely to have symptoms. The other big one that's come to mind more recently in this is this rectus capitis posterior minor muscle. And this is a small muscle that lives back here, kind of right in the middle at the base of your skull. And it's an interesting one because it's one of the only muscles that connects into the dura, or the covering of the brain and spinal cord. And it connects through what's called the myodural bridge. And this is kind of what it looks like, right? You've got this muscle, and the muscle goes from the skull base to the atlas, and then it attaches through this piece of connective tissue into the dura, or the covering of the spinal cord. And if this muscle is working correctly, then the CSF flow can get around the low-hanging cerebellar tonsils, or the Chiari. And if you increase the intracranial pressure here, then this muscle contracts more and it further opens this gate. So it's this muscle that's allowing a Chiari patient to have normal or close to normal cerebral spinal fluid flow. But what happens if the muscle is problematic? What happens if the muscle isn't doing its job? Well, in this case, if the muscle is atrophied, what they found is that you got more back pressure here and the flow decreased. So ultimately, they were able to show that when this muscle was atrophied, Chiari patients had symptoms. When this muscle was not atrophied, i.e. working normally, they didn't have symptoms. So again, this would argue against decompression, right? Because decompression cuts away this muscle. So just realize that if you get a Chiari decompression, it's going to cut directly through this area. And by cutting directly through that area, the muscle is disappeared or the muscle is no longer there. So what you need to realize is that this theory about what's going on, and it was published in a very respected journal, really argues against Chiari decompression in most patients, because the status of this muscle is what we should be paying attention to, not the Chiari itself when it comes to symptoms. So in summary, atrophy of this muscle eliminates the back door to normal CSF flow that's worsened by Chiari. Again, Chiari 1 plus atrophy of this muscle causes symptoms. So there's probably more to this story to be told, and I think we'll see more of this type of research coming out. But what we know so far is that it's Chiari plus something else that equals symptoms. So if you've got Chiari, you want to treat the something else first because that's much less invasive, and the decompression would come last. So again, the research is pointing us in a direction showing that decompression shouldn't really be the first thing we do in these patients, that we should be doing things like trying to make the muscle better, or things like trying to reduce the instability without surgery, not decompressing first. Now, you can always get the decompression if nothing else works, but the research is not pointing in the direction of decompression at this point. So how do you treat these issues? Again, if it's craniocervical instability, try to reduce the instability through injections, not surgery. If it's the rectus capitis posterior minor muscle, then the focus here is that suboccipital nerve that goes to the muscle. And just to dive deeper into that concept, what this study found was that the nerve that goes to the muscle was having problems, and that's what caused this rectus capitis posterior minor muscle atrophy right here, or that's the suboccipital nerve. You can treat the suboccipital nerve, which we've been doing in our CCI patients that have Chiari. And based on this initial research, you can get the muscle to start to recover. You can also work on exercises with a Valsalva maneuver, which is sort of a bearing down type maneuver to try to get the muscle to work again. And this is from some of the stuff we've done in the office, showing that we can get that muscle to turn back on. So in summary, again, if you've got Chiari, it's the something else, Chiari plus something else that's causing symptoms. You got to treat the something else before surgical decompression. So we've been offering the something else and helping lots of Chiari patients get rid of symptoms without decompression. So let me start on some questions because we've got some great questions here. Let me switch over out of this mode here. Okay, so let's get to some questions here. Elving, Anders, I recently had an upright MRI with flexion extension. The doctor's report was that I had a disc herniation from C3 to C6 in load and that the dens was displaced to the right. The doctor said she wanted to do another MRI with rotation tilt to diagnose CCI, what would such an X-ray show me, and what would MRI rotation tilt give you in possible treatment? It wouldn't be rotational tilt. You'd want to do an open mouth lateral bending view on an X-ray, and we've got that on the YouTube channel. So if you go to my YouTube channel and search alternatives to DMX, or just search DMX, it'll come up. It'll show the radiology crew how to do that type of imaging. The problem with upright MRI with flexion extension is it's not very sensitive for detecting CCI. You can detect maybe a third of the CCI that's present that way, but you're probably going to miss about 2/3 of the CCI that's out there. So I think what the doctor is trying to do is to try to see if you have CCI using a more sensitive metric. A much more sensitive metric is a digital motion X-ray, but if that's not available, then a AP open mouth lateral bending view with flexion extension radiographs can substitute. Austin, about 6 weeks out from PICL with 2 to 3 millimeter lower lying tonsils. So a Chiari 0 with type 1C, 2A, 2B. I've had noticed a big difference in so far in CSF flow obstruction type symptoms, mainly brain fog and memory issues. Now that stability has improved. Very great to hear, Austin. Thank you for the update. Anja, good to see you back. Doctor, are there ways to stretch and extend the levator scapula in a CCI patient without much neck stretching and engagement? That's hard, right? Because the levator scap is going to attach in the upper cervical vertebra. So it's going to be very hard to isolate the levator scap and stretch it, because by stretching the levator scap, you're going to put pulling pressure on the upper cervical vertebra. So, at the end of the day, my sense is probably not. There probably isn't a great way to isolate it. But again, you have to look at what the cause of it is. So is the cause of the tight SCM the craniocervical instability? Is it related to scoliosis? And then usually treat the cause. Julie, what is low-hanging tonsils in regards to Chiari? Yeah, Chiari malformation just means there is low-hanging tonsils to various degrees. A 0 is at that line or up to 5 millimeters. A 1 is below that 5 millimeters. And then a 1+ is below 10 millimeters. Carol Yates, made advanced by Chiari. Do you prefer that we are put into alignment right before we do a DMX to send to you, or is it more important that you see DMX normal state of out of alignment? I would say out of alignment is probably better, Chiari. Elving, if a neck brace makes me feel better for a moment, but I feel worse the next day, is that something you've heard before? Could it mean more than one illness? What it could mean, Elving, is just that the neck brace itself is causing other secondary issues. So, for example, sometimes it puts pressure on the occipital nerve, and that then can cause more headaches. Or it could be being in that specific position is causing more swelling in certain upper neck facet joints, etc. Anja, in your opinion, do tonsils lying around 3 millimeters qualify as Chiari 0? Do you have to take the 5 mm criteria as the crucial one? Yeah, that's a Chiari 0 or CTE. If it goes below 5 millimeters, we call it a Chiari 1. Greg, just hello and thanks for your time. I hope your sabbatical treated you well. Heading to Colorado from Santa Fe today. DMX tomorrow. Look forward to meeting with you Tuesday. Be well. Oh, great to hear from you. Looking forward to seeing you on Tuesday. It's been advanced by Harry Winston. We have Regenix location locally. Should we see what they can do to stabilize us before considering traveling internationally to see you? Yeah, that all depends, Harry, on the type of CCI. So if you've got, for example, type 3A, then by all means, have them give it a shot. That's because advanced posterior injections can really help type 3A patients. If you've got a type 2B, probably not worth having the local site treated, because you're much less likely to be helped with that kind of CCI and advanced posterior injections only. Julie, Dr. C, can you tell me if rectus capitis muscle is atrophied on PICL? Julie, that's something we can see on a routine MRI. So I would just need to look at your routine MRI to see that. Anja, can we rehabilitate the RCPM muscle if we have CCI? Yeah, so Anja, we studied that in the office, and it seems like that Valsalva maneuver, that's where you bear down, is the one that activates it. So if you can do that Valsalva type maneuver, that can try to activate the muscle. And then obviously active type physical therapy like laser exercises can also help it rehabilitate. So those are the kind of things that you might want to do. Robert, not easy to fix exercise RCPM without fixing the CI. It's already overworked. Adding exercise will flare up symptoms. Yeah, you're Robert. Robert, I think you're right in most patients, but I think we'll also see that some patients will be able to rehab it. It really depends on the severity of CCI. So we have exercise intolerant CCI patients. That's most of the patients we see. But there's also exercise tolerant CCI patients who can rehab their way out of it. Allie, how long is the BMAC procedure? Do we have to be put under sedation 2 times for a 3B? Bone marrow aspirate procedure itself is usually about 30 minutes. You can do it straight up with just local anesthetic. It really depends on the patient and how they'll tolerate that. And in that case, you would only have to be put out once for the PICL procedure. So it's really up to you and how well you tolerate those kinds of procedures. Some patients do it straight up with just topical anesthesia, and they seem to do fine, but that probably wouldn't work for most CCI patients. Kevin, Dr. C, hope you're well. So crepitus go away with Regenix meds. I don't know what Regenix meds you're talking about. Maybe you're talking about the supplement. If the crepitus is due to inflammation, then that could be possible. But if the crepitus is due to instability, then no, you wouldn't expect that. Ali, extension translation at 2.3 is 3.7. What is normal extension? You get up to 0.7 millimeters at C23 in extension. That's the normal limit. So a 3.7 millimeters of 2 going backwards on 3, or a 2-3 retrolisthesis in extension would be well over that 0.7 millimeter mark. Okay, any other questions I can answer out there? We've had some good questions. We have fewer people on today just because I haven't done one of these in 6 weeks. That's always the case. I didn't really have much time yesterday or really much energy yesterday to try and get advertising out, just because I'm still pretty jet lagged. Today I'm much better. Kevin, will crepitus go away with Prolu or PRP? Yeah, Kevin, it just depends on what's causing the crepitus, right? The first part of this process is always getting a CCI type. You can't be treated accurately without a CCI type. So that's 2B, 3A, 3B, 1A, 1C, etc. Once we have that type, then we can map that to a treatment. So for example, if you have a type 3A, then the crepitus will probably go away with good image-guided Prolo or advanced PRP posterior injections. But if you have a 2B, those are unlikely to do anything. And it's a waste of money usually. Robert, mind explaining how BMA would go without sedation? Yeah, Robert, when we first started doing bone marrow aspirates, a long time ago now, 20 years ago, we didn't use IV sedation, and we kind of learned a numbing technique that worked well. And so ultimately, it can be done without sedation. Now, the CCI population is a little bit different. The CCI population tends to be more pain sensitive. So because of that, that might go a little rougher with most CCI patients. Having said that, we have some CCI patients that choose just to do local numbing, and they seem to do fine. So again, we always offer that option. How is post-PICL if one travels alone? Yeah, Robert, we require you to have a nurse for that first night in the hotel, just so that you have someone there that's your advocate. Uh, so again, we don't recommend traveling alone at all with a PICL procedure. And if you are traveling alone, you've got to hire someone for the first night so that they can act as your advocate if there's any problems, issues, etc. Jenny, I had a PICL 7 weeks ago, had a very bad CO2 overlap. My neck posture plays a big role in remaining symptoms. My POTS, like blood pressure drops and physical weakness and instability. Walking are still bad. I'm rehabbing and doing PT. Would it be kind enough to give any recommendations for rehabbing and strengthening? Yeah, Jenny, the recommendations are all online. So if you go to my YouTube channel and you look up rehab, for PICL, then that's where that's going to be. There's about a dozen videos there. So let me see if I can get this for you. So if you go to the YouTube channel and just go to videos, this is the way I find it. Just go to videos and go down a little bit. You will see it. So it is, they start right here, the how to rehab here, how to rehab from CCI, 3.2, 3.1, 3, 2. So you got to go to the first one, how to rehab from CCI part 1. And then that'll go to the second one and third one and the fourth one, et cetera. So that goes into great detail how you want to rehab from all of this. And at the same time, you also need to be talking to your doctor, because your doctor will be able to tell you how to proceed. Julie, welcome back. By the way, I'll see you next month for the second PICL. Great, Julie. Look forward to seeing you. Thank you for welcoming me back. Still pretty jet lagged. I have a hard time saying welcome. Elving, are you not supposed to be on YouTube? I don't know what that one means. You can, for this, you can be on YouTube or you can be on Facebook. So we stream to both of those, YouTube and Facebook. And let's make sure. Oh, you know what? It may not be streaming to YouTube right now. So I apologize. That's my mistake with some jet lag. I think I didn't set up the YouTube stream correctly this morning. So it looks like we're probably only on Facebook. So I'll have to fix that for the next one. This will also be available on YouTube. So I'll upload this to YouTube. But again, that was my fault. So it looks like it's only streaming to Facebook right now. Sven, is the stem cell type different with the PICL infusion? I'm not quite sure what you mean by that one, Sven. Is the stem cell type different with PICL infusion? So I need more information to answer that specific question. How is your DMX doing? When is it open for visits? Yeah, Elving, my guess is because of some delays in getting the unit, my guess is we won't have it till earliest beginning of the year, and possibly not till February or so. So that one's going a little bit slower than I had hoped. Lindsay, how often should we get an MRI, DMX, or other imaging? Do the original MRI and DMX give enough information if I need 4 more PICLs? Yeah, Lindsay, we generally don't repeat imaging unless there's a specific reason to repeat the imaging. So you should be fine based on what we used for diagnosis. And if we need additional imaging as we go, we'll let you know. Vera, hello, Dr. Centeno, and how many posterior neck prolotherapy sessions would you recommend while waiting for telemedicine consultation? So far, I know I have C2 through anterior subluxation and further down posterior subluxation. Just want symptoms relief in the meantime. Yeah, again, Vero, it just depends on the type of CCI that you have. If you've got a type 2B, then you're probably wasting your money. If you've got a type 3A, then usually those are done every 4 to 6 weeks. Gotcha, Greg. Yeah, that's my fault. I think my jet lag self this morning it kind of defaulted to the Facebook on StreamYard, so I think that was my fault. I didn't add in the YouTube's stream. Alex, she means it's on YouTube today, assuming she wants to start. Yes, gotcha. So I'll post it on YouTube once I get it all done here, and I apologize for that. Alex, thanks for answering all my questions on Reddit the past few weeks. PIC with Dr. Schultz in 3 weeks. Great, Alex. Yeah, as you know, I try hard to get to answer that multiple times a day, just because I know this is a very difficult area to get reliable information. And I find that having access to a physician expert in this space helps patients try to thread that needle of using social media and patient interaction as a support, but not getting led down crazy rabbit holes that don't make a lot of sense. Vera, welcome back. Thank you for your dedication, answering questions, and helping us out. Much appreciated. Happy to help. Again, I enjoy doing this. I enjoy connecting with patients. I enjoy trying to help them through all this. Even if I never see them, I always try to see if I can add something, if it's possible, and I can't always, that can move them in the right direction, because this is a difficult problem to have. And it's very easy to feel very lost if you've got CCI. I often state that my patients describe being like a pinball in a pinball machine. They go from specialist to specialist to specialist, not getting many answers, and in the meantime going a little bit crazy because they're not getting many answers. So thank you for the welcome back. Okay, guys, I'm not seeing too many more questions here. I'll do one last call for questions. And next time, obviously, I'll make sure we have this both on Facebook and YouTube. That was my bad. Any other questions I can answer? Oh, here we go. We got a couple. Elvin, can you explain a little more about telemedicine step by step, how you send the x-ray image, what programs to talk to you, etc.? Yeah, so we do telemedicine over Zoom. You can upload your images to a secure server that we have. You have to have movement-based images, meaning we don't accept just a routine cervical MRI. So you have to have movement-based images for us to review, at the very least an upright MRI with flexion extension and or a DMX or equivalent. I also personally screen every single patient that applies for a telemedicine. That takes a little extra time, but it's worth doing to make sure that they have enough information where we can actually get to some sort of conclusion. I do that because it's very disappointing for patients, obviously, to wait to get on telemedicine and then get on telemedicine, only to realize that we don't have enough information to make a decision. So I personally screen all of those to try to make sure that the patient has enough information, or if they need more information or need more imaging, that they know to get that before the telemedicine. Vera, I've been watching you, and thanks you didn't get cortisone injections for set nerve ablations. Oh, thanks to you, I didn't get them. Well, great. I'm glad to hear that, because I don't think facet injections with steroid and radiofrequency ablation is the best that we can do in 2025. It was the best we can do in the late 90s and even early 2000s, but somewhere around 2010, it started to become not the best we can do, but it's still the most common thing that's offered. Alex, so far I'm scheduled for, oh, I'm sorry, I missed that one. Alex, for someone highly functional, PT doesn't necessarily flare me, just doesn't make much gains. I have 8mm overhang. Should I continue PT exercise? Or should you continue PT exercises immediately, or should I wait a few weeks after PICL? Yeah, if you don't get flared from physical therapy, I think you can cautiously move into physical therapy and back into physical therapy. Again, threading the needle means that you're constantly trying to gain strength without causing a flare-up. So if you don't get a flare-up, then I think that's fine, but I'd be a little cautious for the first 4 to 6 weeks after the procedure. Ali, so I'm scheduled for BMAC for type 3B of 3.7. Do you think that would be a good choice? It just depends on what we're talking about there, meaning, Ali, BMAC is what's injected, but it's not the procedure. So I would need to know what procedure you're contemplating. So in order to treat a type 3B, that would be an anterior injection through a PICL approach. So I'm assuming you're getting bone marrow aspirate concentrate or bone marrow concentrate, which is what's injected, through a PICL approach, which is how it's injected. Vero, do PICL patients get relief from visual disturbances? I have a lot of trouble reading after a brain and neck injury. Vision therapy didn't help at all. In general, yes. Our CCI patients that have vision issues due to CCI tend to get relief of those vision symptoms once we treat the upper cervical spine and reduce that instability. Okay, guys. Well, I'm going to probably end it there. I want to thank everyone for all the great questions. I did want to start getting back online today and getting back to my weekly Q&A sessions, which I kind of missed while I was gone. And I want you to have a great week. And I'll continue answering questions on the Reddit thread. So if you are not on that thread, it'd be a good time to join that so you can get questions answered 24/7, 365 there. Alex, last question. Do you usually see people start to hold alignment longer after the procedure? We do, Alex. In general, that's what we see. Elving, who do I contact to prepare a PART medication? Don't know what that one means, Elving. Maybe to do a telemedicine, that would be ISIS in our office. So you go to the website and contact ISIS. Okay, guys, thanks so much and have a great week.